If you're navigating nursing school right now, you know it's just a ton of information. You really need study material that cuts to the chase, focusing only on what's likely to be on the exam.
And that's exactly our plan today. We're doing a concentrated, exam-focused deep dive. We're pulling out the highest yield stuff, definitions, processes, key relationships from those excerpts covering chapters 10, 11, and 12.
Yeah, the goal isn't just definitions, it's about application. We're
Yeah.
connecting three really critical areas for RNs: how the nursing role is changing with care transitions, how leadership deals with liability, and those absolute must-know rules for delegation and managing change. Let's make this count.
Okay, let's start with chapter 10. The concept that really defines today's healthcare system is care transitions.
Right, like the Miss Jeffries scenario, the patient with heart failure getting readmitted over and over.
Exactly. And the big takeaway here, both clinically and financially, is that healthcare is fundamentally shifting. It's moving out of those expensive hospitals and into the community.
And that shift completely changes the risks for the patient, doesn't it? We think about hospital tech, but when the nurse moves to that promotion and prevention model at home, what new hazards pop up? What does the nurse have to teach about?
Well, the hazards definitely change, but they don't vanish. In the hospital, risks are things like infections, complex medication errors, high-tech problems. But discharge sends the patient home.
Where family members suddenly become caregivers.
Precisely. And those previous hospital hazards, they become risks the family now has to manage. It's a huge shift in responsibility.
Okay, so the high-yield content here is really nailing down that expanded RN role in the community. That means, like, super comprehensive teaching, solid discharge planning.
Absolutely. And medication reconciliation have to make sure every single pill is accounted for, understood. Plus, crucial follow-up checks. It's all about bridging that gap, that transition from hospital to home.
Makes sense. Now, what about communication pitfalls? The example with Joe Reynolds, the RN, and his neighbor with the high PSA test. That's a classic test scenario, right?
Oh, definitely. It's essential because it highlights basic human psychology under stress.
So the patient hears the word cancer, potentially linked to the PSA result. What happens in their head?
It's almost like an immediate cognitive shutdown. Emotional distress takes over, and they just start processing. They miss the rest of the important information.
Like the need for follow-up or that other things can cause high PSA.
Exactly. The scary word just overshadows everything else, and that's where the nurse becomes critical.
So the testable strategy is keep it simple, focused teaching. Reinforce the immediate next step, the follow-up. You're not explaining the whole potential diagnosis, just ensuring they take that next crucial action.
Precisely. You're the lifeline for that next step.
Okay.
Another key teaching topic: complementary and alternative medicine, or CAM. For exams, you have to know the two main ways these are classifying.
Right. First, the big system-based examples. Like traditional indigenous systems, think traditional Chinese medicine, acupuncture, herbs.
And things like homeopathy and naturopathy, often put under unconventional Western systems.
Got it. But then there's the second classification, grouping by how they work, the therapy classification. That's where things like biofeedback fit in, isn't it?
Exactly. You need to know those categories.
Okay, so if I see biofeedback, imagery, meditation, prayer, that's mind-body medicine.
That's right.
Special diets, supplements, vitamins, biologically based practices, chiropractic massage, manipulative and body-based practices.
Right.
And finally, therapeutic touch or Reiki. That's energy medicine.
Knowing that structure is vital. And let's not forget the huge patient safety issue from the Mabel Wilson case. Why is it absolutely non-negotiable to document all supplements and OTC use?
Because they can interact. Even something seemingly harmless can mess with prescribed meds, causing serious harm. If Mabel doesn't mention her herbal stuff and the doctor prescribes something that uses the same metabolic pathway, big trouble. Liability issues, too.
Absolutely critical.
Yeah.
So, quick recall check for Chapter 10. In that community health transition, who's primarily responsible for the comprehensive teaching and med reconciliation needed to minimize home hazards?
That's the delegating registered nurse.
Correct. And which care and classification includes biofeedback and imagery?
Mind-body medicine.
Perfect. Let's move into Chapter 11, leadership, liability, performance.
Okay, shifting gears from patient teaching to how things run. Leadership theories. We need to separate the older trait theories from the modern ones that really matter now.
Right. The trait-based theories are kind of historical, but you still need to recognize them. Great man theory leaders are born. Patrician theory based on perceived traits like height, background, Charismatic, theory-inspiring, often in crisis.
But the ones that show up on tests and in practice are the contemporary ones, transactional versus transformational. How do I clearly separate transformational with its four parts from just, a basic reward system?
The core difference is mutual growth. Transactional is a straightforward exchange. Rewards for doing the job, maybe punishment for not. It keeps things stable.
Okay, basic management.
Right. But transformational leadership is about lifting everyone, leader and follower, to higher levels of motivation, focusing on a collective purpose.
And those four components are key. Let's list them again, maybe with a quick idea for each.
Sure. 1. Idealized influence, being a role model, earning trust.
Yay.
2. Individualized consideration, treating each person uniquely, like a coach.
Mentorship.
Exactly.
Huh.
3. Inspirational motivation, painting that compelling vision for the future.
Getting people excited.
And 4, intellectual stimulation, encouraging people to question things, think outside the box.
And the really high-yield finding here is that autonomy is the biggest predictor of job satisfaction with this style.
That's the big one. It flows directly from that individual consideration and intellectual stimulation. Huge for retention and morale.
Makes sense. Now, connecting leadership to the legal side. Liability. The vaccine error, Hep A instead of Hep B. Who's on the hook and why do these errors happen?
Well, the liability is shared. Both the nurse who drew it up and the physician who gave it are involved. These happen often because busy environments can lead to relying on habit instead of rigorously following the 5 rights.
Right patient, right drug, right dose, right route, right time.
Every single time. Prevention comes down to strict adherence and double-checking. No shortcuts.
And it gets even more complex with students, right? Like Jack's case, the medical student gives an injection, causes bursitis. The critical question for liability is, who's ultimately responsible when a student or someone you delegate to causes harm under supervision?
The buck stops with the supervising professional, period. Whether that's the RN or the NP, like Karen in the example, their job includes ensuring adequate, constant supervision. If poor supervision leads to injury, the certified staff member is liable.
That leads right into performance feedback. Jessica thanking her charge nurse, that simple positive reinforcement, it motivates the supervisor. But giving negative feedback, like with Richard being late all the time, needs a specific process.
Yes, a very testable 3-step process.
Okay, step 1. Start with something positive. Acknowledge strengths or effort. Don't just jump into the negative.
All right, soften the approach. Step 2, be specific about the concern. Not, you're late, but you were late Tuesday and Thursday by about 20 to 30 minutes, which impacts shift report. Concrete details.
And step 3, the crucial one for accountability.
Place the responsibility for finding the solution squarely on the employee. The manager asked Richard what he could do about it, like setting his alarm earlier. This creates ownership.
That makes total sense. Puts the ball in their court. Okay, quick exam link. Which leadership style boosts autonomy and has those 4 components: idealized influence, individualized consideration, etc.?
That's transformational leadership.
Got it. Let's move to Chapter 12, motivation, delegation, and change.
Right. Chapter 12 gets into the engines of the organization, starting with motivating staff. You need to know these theories for application questions.
Okay, 3 main models. First, Maslow's hierarchy, the pyramid, right? Basic needs like safety and physiological have to be met before you can worry about self-actualization.
And the application is, hospitals need to provide good working conditions, meet those basic needs if they want to attract and keep staff. It's foundational.
Then there's Herzberg motivation hygiene. This one feels like classic matching question territory.
It often is. You have hygiene factors like decent pay or working conditions. These are dissatisfiers, meaning if they're bad, people are unhappy, but making them good doesn't necessarily motivate people to achieve more.
They just prevent dissatisfaction.
Exactly. Then you have the motivators, things like recognition, responsibility, achievement. These are the satisfiers that actually drive performance and job satisfaction.
That distinction is key. Okay, and third is McClellan needs theory. What are the core drivers there?
McClellan identified 3 main psychological needs: the need for affiliation, belonging; the need for power, control, influence; and the need for achievement, succeeding, excelling. People are driven by different combinations of these.
All right, now, maybe the most critical concept overall, delegation and accountability. This is high stakes.
Absolutely non-negotiable for safe practice and for avoiding liability. Let's state the core principle first.
Okay. The ultimate responsibility and the liability for whatever happens with the delegated task, it stays with the delegating registered nurse, RN. Doesn't matter who actually did the task.
That's the bedrock. And from that flows the inappropriate delegation scenarios. You have to know the red flags. The source material gives 3 big ones. If a task gets any of these, you cannot delegate it.
Okay, red flag 1. The activity is outside the delegatee's scope of practice or their proven capability. Simple enough. They aren't allowed or aren't able to do it.
Right. Red flag 2, and this is probably the most tested. The activity requires independent, specialized nursing knowledge and judgment.
Why is that one undelegatable?
Because tasks like assessment, evaluation, or specific teaching that requires critical thinking are legally and ethically the RN's domain. If it requires judgment, like figuring out if a complex wound looks infected versus just changing a simple clean dressing, it stays with the RN.
Got it. And the third red flag.
The work situation doesn't allow for adequate supervision. Delegation isn't dumping a task. You have to be able to supervise.
So back to the example. RN delegates a simple dressing change to an HCA, but the wound gets infected. Who's liable?
The delegating RN, always liable for the outcome.
Crystal clear. Okay, finally, change management theories. Lewin's stages.
Right. Lewin's stages of change. It's a process. Unfreezing, movement, and refreezing.
Unfreezing is getting ready, seeing the need, gathering data. Movement is actually doing it, implementing the plan. And refreezing is making it stick, right? Why is that stage so important and apparently difficult?
Because change is hard. People and systems naturally drift back to old habits. Lewin said refreezing takes like 3 to 6 months for a change to become routine. So managers must actively reward the new way, reinforce it constantly during that time, or the whole thing could just unravel.
Like we saw with Janet standardizing the handoff, she had to overcome resistance. How does she do it effectively?
Good communication. She explained the why it was a joint commission safety requirement, not just her idea. And crucially, she involved the staff in figuring out the how. That tackles both active resistance, like frustration, and that passive stuff, like just ignoring the new process.
Makes sense. Get buy-in.
Right.
Okay, let's wrap this up.
So we've really hit the core managerial and legal pillars for the RN role today. We looked at that big shift to community care, the inescapable liability tied to supervision, telling transformational from transactional leadership apart, and the absolute rules for delegation and change.
Yeah, mastering these things like the 4 parts of transformational leadership or those 3 red flags for delegation, it's more than just passing the test. It really gives you the blueprint for practicing safely and ethically. Understanding the why behind these processes helps you grasp where your accountability truly lies.
Absolutely. So as you review this, maybe think back to those scenarios we discussed. Mrs. Jeffries' risks at home, the shared liability, and that vaccine mix-up. Here's a thought to chew on. How does the intense, high-stress, high-tech environment of the modern hospital potentially contribute to the very risks we're trying to manage? Things like poor patient compliance, medication errors, communication failures, the things that often lead to lawsuits and readmissions.
That's a deep question. Connecting how the system itself, the environment, interacts with individual actions and liability, that's where real leadership thinking comes in. It's not always just individual errors. Sometimes the system sets people up for failure. Considering that link between system design and your role is crucial as you step into practice as an RN.
Keep that perspective in mind. That's it for this deep dive. Good luck with your studies.